So first of all, the intended use of using the FARAPULSE system. Mainly, it's indicated for the paroxysmal AF patients who's dealing with several episodes of AF, and now we have the FDA approval for also the persistent AF doing the posterior wall isolation using our FireWave catheter as well. So now we are going to talk about the system overview. So we have the FARSTOL, which is the pulsed field ablation generator, and the FARDrive, which is our transparent sheath, and the FireWave, the catheter itself, that we can deliver the source of energy through it. And this this is the recording system module, the RSM. This is a very important part, equipment that we need to use it during our PFA cases, because this acts like a switch. It prevents any leakage of the electricity that could damage any other capital equipment inside the cath lab, or maybe any leakage to go back to the patient. So now we're going to talk about the FARDrive, which is the sheath. It's a steerable one, unidirectional one. The inner diameter is 13 French. The outer is 16.8, so it's a quite big sheath. So it's highly recommended to take the femoral axis under the guidance of ultrasound. As you can see, we have a radiopack marker to be visualized under the fluoroscopy, and it's a clear sheath, so it's a transparent one. You can see the bubbles and everything that could be inside the sheath, and here the hemostasis valve and the three-way stopcock. And this is the FireWave catheter. It's over-the-wire technology, so we have here a wire that is already inserted inside the catheter. It comes in two sizes, 31 millimeter, in the fully deployment mode, which is the flower configuration, and the 35 for maybe complex anatomy or bigger chambers. As you can see here, we have the deployment slider. We have three configurations: the undeployed mode, and the basket, which is the partial deployment, and the flower, the full deployment. And we have the guide wire lumen and the flush port and the connection cable as well. So now we have mentioned the system components, and to perform a PFA case, we need additional supplies, which is heparinized saline, 35-inch guide wire, at least to be 180 centimeter, because the FireWave catheter is taller than 150 centimeter. And if you're going to do the transeptal approach using the FARDrive sheath, just need to have a very long needle. Otherwise, you can use your fixed sheath and the small one. And for sure, it's highly recommended to have at least 20 cc syringe to flush the catheter and the sheath. So now we're going to talk about the preparation of the sheath. So first of all, we remove the sheath components from sterile packaging. And as now we are unlocking the deflection mechanism. Here's the 20 cc syringe. And this is a very regular procedure to flush a sheath.
What does it show? Who orders it?
We just need to make sure that the sheath and the dilator itself has no bubbles or something. So this is, we always recommend to have at least 20 cc syringe. Now the sheath is ready. We just need to introduce the dilator inside the hemostasis valve slowly because it's a very sensitive valve. And now it's ready. And this is the preparation and the instructions for the catheter itself, the FARAWave. As you can see here, we have the flush port and the guide wire lumen that both needs to be flushed, also with a 20 cc syringe. So as we mentioned, it's over-the-wire technology, so you need the wire to be inserted inside the lumen to have the deployment and the undeployment configurations, which is basket and flower. Now we have the basket shape and the flower shape. Never do the deployment and the undeployment configuration without seeing the wire outside the catheter. And now this is regarding the connection cable that is directly connected to the Firestore, which is the PFA generator. This is already mentioned in this the previous slide. So the most important thing that the basket, the partial deployment mode, is very good for the osteal positioning and the self-centering capability, and for the flower, for the antral positioning and radially widest lesion. So how to introduce the FARAWave catheter into the FAR drive sheath inside the left atrial cavity. As you can see here, we have two fluoroscopic markers in the FARAWave catheter and the one in the FARA drive sheath, and it's highly recommended to deploy and to get the basket shape, the partial deployment configuration inside the left atrial cavity itself, not to be very close to the pulmonary vein ostium. This is what we have already mentioned. Do not deploy the catheter very close to the pulmonary vein ostium. So now we are going to talk about the dosing and the PVI workflow overview. So many years back, I guess 2013, after the foundation of FARAPULSE, the original company, just before the acquisition made by Boston Scientific, we had several configurations and workflow for the PFA dose. We started with the monophasic, which is the durability of the pulmonary vein isolation was not that good. It was 45%, and then the biphasic one, it was quite good, 84, and for the optimized biphasic workflow, which is the OptiWave 4 paired applications, total 8 per vein, we had the durable pulmonary vein isolation percentage by 96%. This is a small video explaining how the OptiWave dosing is done. So now we have the basket shape. We deliver 2 applications in this orientation. The application duration is 2.5 seconds. Now we have clogged or counterclogged the catheter by at least 36 degrees and have 2 other applications. And now we go to the flower configuration. 2 applications, rotate the catheter clock or counterclockwise by 36 degrees to have the other pair of applications. So this is an OptiWave. 2 applications, rotate 2 applications, then deploy to the flower, 2 applications, rotate 2 applications, and the pulmonary vein should be isolated. So how to optimize the coaxiality contact? Just need to have alternative imaging solution like the CT, that provides a 3D visual understanding of the pulmonary veins and their branches to support device positioning and select device size. Maybe the angiogram and the 3D mapping system as well. So how to perform the delivery? So we called it AAA. So there is 3 considerations that we just need to look at it during the application, just before it and after it. So the ACT time should be larger than 300. The air management, you just need to aspirate always the third drive sheath because it's quite big sheath. And to give atropine just before delivering the application to avoid any vagal response that may occur. So at the very beginning of this case, the backup pacing from the RV was highly recommended, but now not, because in the manifest PF registry, we have noticed some perforation during the during the PFA application. So now if you just need to avoid the vagal response, just need to give 1 milligram atropine before performing the first application. And this is a direct approach for wiring, yes, from the left-sided veins to right-sided veins. It's highly recommended to go from the left to right in the flower shape. And for the positioning consideration, it's highly recommended to advance the sheath in the tip of the catheter in the flower to allow optimal sheath torque transfer, and for the basket to be a little back proximal to the marker, allows basket to self-center. And this is how to deploy the catheter in the basket shape. You should cover the whole ostium of the vein. Other complications or consideration actually. So we had a misuse at the very first beginning of using the FARAPULSE technology. Misuse from several, maybe in high volume centers in Europe, using the catheter, doing, for example, the mitral isthmus line or the CTI line, and that caused a lot of complications regarding the coronary spasm. And also the high total number of applications may increase the evidence of the hemolysis. So it's highly recommended not to exceed now, as the latest publications, not to exceed 54 applications for the, yes. And last thing, the dosing consideration, if we're going to talk about the abnormality of the, the abnormality of the veins, and for the small chambers or anything, not to make any corridors for the posterior wall. So for the large abnormal veins, we consider it, we can give additional applications if necessary. And for the common ostium vein, we deal with each vein as a separate one. Thank you.
Thank you, Mahmoud. We can open for discussion, few questions, so that we can keep on time with the schedule. Okay, FARAPULSE or pulse field ablation is a new generation of energy treatment, and the main concern was to minimize the complication of radiofrequency and cryoballoon ablation. And what are the most important complications of radiofrequency or cryoballoon ablation is atrioesophageal fistula, which is a fatal condition, and phrenic nerve palsy. So when they discovered that this technology is capable of avoiding all these complications, then it is booming all over America and Europe. It is very expensive in Egypt. We started doing cases, but very, very, very expensive. You have to explain to the patient that the results are the same with the pulsed field, with the radio frequency, and with the cryo. You cannot deceive the patient. You have to tell him the recurrence rate is the same, but the safety is higher. Some patients, Egyptians who work in Saudi Arabia, come to us and say, I need ablation, pulsed field ablation. Okay, welcome, but you will have to pay for this technology. So the innovations is very excellent and very booming and very satisfying for the doctors, but is very depressing for the patients who need it. Thank you, Mahmoud.
Thank you, Dr.
David.
Thank you, everyone.
What is your experience in the States with the FARAPULSE?
So it's taken over, it's been very enthusiastically adopted in the United States. The other advantage is that it's very fast. So you can isolate the pulmonary veins in a very short period of time. So a very busy user will find that the cost is still compensated by the number of procedures they can do in a day. And I think that's the factor that's appealing. But yeah, as you point out, it's costly. From a pediatric perspective, it's a large deployment system, large access. So probably a limited use in my pediatric world, and for sure the catheter cost is much higher than a conventional catheter. So, thank you.
Sir, yeah, I know you mentioned about not using the RV catheter for pacing. We still do. We avoid giving atropine, unless it's really necessary. And you develop quite a strong vagal reaction, of course, when you're delivering energy. But the perforations or pericardial effusions we've seen is more related to the wire. You really have to get the tip of the wire very close to the nose of the catheter. And it occurs when you're moving, from one vein, to the next, especially if you are moving along the posterior wall, which most people like to do. So I think for me, I think that's where a lot of care has to be lies. And normally I just put a catheter in this bundle position and use it to pace, whereby you're not really at the apex of the ventricle. And so that helps to improve the safety of the procedure. It's like David said, one of the advantages is that it also enables us to treat sicker AFib patients because you're not using all that volume overload that comes with RF, and we are taking on more complex AFib ablations that otherwise you will have shied away from. Yeah, but a very good presentation. Thank you.
Thank you so much. So regarding the perforation, regarding the guide wire itself, so I totally agree with you. So we have developed the guiding wire because it was like a straight tip at the very first beginning, and now it's a must to have a J-tip wire or a big tail one. And we have several guide wires that is highly recommended from Boston Scientific side. You may have it in your market, you may not, but always keep an eye to have the recommendations, the recommended guide wires that already Boston Scientific was talking about it. So for the RV backup V pacing, this thing is also noticed during the Manifest 17K registry that some of the physicians needs to prevent the vagal response after delivering, especially the first application. And we have noticed also some perforation in the RV, not in the left atrium, because of the guide wires. So now it's highly recommended to have 1 milligram atropine at least before delivering the first application, instead of having an RV backup catheter in the apex. Thank you.
I have to move to the last speaker of this session, Dr. Musallami.